Yes, you can begin, sir.
Okay. Good evening, everyone. So, welcome to the another bi-monthly meeting of our neuromuscular subsection meeting, where which we will be discussing some topics at each one of the centers from India will be presenting. This time, JIPMER will be presenting under Professor Dr. Vaibhav Vavdekar from JIPMER. So he and his team will be presenting this time in the neuromuscular subsection meeting. So we just started a couple of minutes late. So without wasting much time, I will call him. Before that, just want to invite you, all of you, to the IAN neuromuscular subsection meeting during the IAN Con Madurai, which will be on 15th afternoon. We invite all of you to join us in our subsection meeting. We'll have some neuromuscular blitz of interesting cases which will be presented there. So please make sure that you come and attend the subsection meeting also. Over to you, Dr. Vaibhav. So you can introduce your first team and ask them to call the first person to present. I think you're mute, Dr. Vaibhav. You're mute.
Thank you, Dr. Vishnu, for that kind introduction. Thank you, all the organizing people. Thank you, IIN team and the digital team for giving us the opportunity to participate in this reputed forum. So without taking much of the time, we will today's outline will be presenting first two cases, and then we will try to link them and try to study the approach of limb-girdle muscular dystrophy, which is so commonly seen and so commonly discussed in all the exams. And we also encounter them in all the neuromuscular clinics. So first presentation will be Dr. Raghavendra. Subsequently, Dr. Jairam will present, and then I will present the approach. And finally, Dr. Rajeshwari will discuss the genetics and MRI role nowadays, which is both of which are now revolutionize the neuromuscular disorders. So Dr. Raghavendra can proceed with the case.
Thank you, sir. Hope I'm audible, sir.
Yes, you're audible. If you could move to the full screen.
Make it in the full screen.
Yes. Good evening, everyone. I'm Dr. Raghavendra, Senior Assistant from the Department of Neurology in JIPMER, here to present a case of 29-year-old nurse who has brought to the chief complaints of weakness of both the lower limbs for 14 years and weakness of both the upper limbs for 13 years and difficulty in turning in bed for 4 years with the age of onset around 15 years of age. Weakness of both the lower limbs for 14 years. Initially, the patient, when she was studying in 10th standard in school, around 15 years of age, she noticed difficulty in getting up from the squatting position for 14 years. She used to sit down on the floor and used to have lunch. After lunch, while trying to get up from the squatting position, she used to support her hands on the floor and then get up from the sitting position. The weakness progressed over the years, and 1 year later, after using the restroom, she had difficulty in standing from the squatting position. She started taking the support by getting up with both hands on the floor. And then 3 years later, she used to support with one hand on the floor and then on her knees and then gets up. Due to the progression of this weakness, she later used to grab the support of nearby chair or stool for getting up from the squatting position. 2 years later, she also developed complaints of difficulty in climbing stairs for 12 years, which was initially upstairs followed by downstairs. During her school days, she was able to climb stairs without anyone's support. However, when she came to college, she required the support of nearby railings or walls to climb upstairs. And initially, she was able to climb alternate steps at a time, but later she was able to climb only one step at a time. While going to college, she also had difficulty in getting onto the bus footboard, for which she was initially able to manage by holding onto the bus railings. But then a few years later, she had to hold both the railings and then jump onto the bus, as she had difficulty in lifting both her legs from the ground. And sometimes she used to initially sit on the bus footboard and then get up with the support of railings. Currently, she does not get into she is not able to climb the bus with high footboards. 4 years later, from the onset of weakness, she also developed difficulty in climbing downstairs for 10 years. She had a feeling of giving away of her knees while trying to climb downstairs, and her knees used to buckle and she used to sit down on the floor. Thereby, she started taking support of nearby railings and keeps her knee extended to avoid the buckling. And her mother also noticed that while walking, she had to throw her leg forwards while walking. Initially, she was able to walk without support. Currently, she requires support in walking as well to prevent the knees from buckling. Around the same time, she also developed difficulty in standing from the sitting position for 10 years. She needed support with both hands in getting up from the chair or stool for the last 8 years. And currently, she also requires 1% support for getting up from the chair for the last 1 year. 2 years later, she also developed difficulty in sitting from the standing position, such that when she was trying to sit from standing position, she suddenly sits on the stool. 1 year later, she started developing distal weakness in the form of difficulty in wearing the slippers for 7 years. She had difficulty in guiding the feet into a slipper, and which later progressed, and she had slippage of slippers, which she was aware of. She also noticed she had difficulty in lifting the foot while going upstairs, and sometimes her foot dragged while trying to go on to the next step. She also noticed she had tripping of feet while climbing stairs. The patient also noticed that while sitting on a chair that her foot hangs down, this was all associated with the looseness of limb while walking. This was later associated with weakness of both the upper limbs for 10 years. The patient noticed weakness in both the upper limbs, initially in the form of difficulty in lifting heavy weights over the head, which later progressed to the difficulty of pouring water over her head at the time of bathing and while trying to wear dress and combing hair. She later had difficulty in bringing the food to the mouth, and so she had to bend her head down while eating the food. However, she is able to mix food and write normally. Currently, she requires support in combing hair and wearing shirts. In the last 4 years, she also developed difficulty in turning in bed, such that she needed support of both hands in turning in bed, but later it progressed and she is now currently not able to turn on her own, and she requires nearby support or family members in turning. She has also difficulty in lifting the trunk from the bed. However, there was no history of difficulty in lifting the neck from the pillow. All this difficulty was associated with looseness of all 4 limbs. Now, this is the whole summary of weakness timeline, which initially started with the proximal lower limb weakness in the form of difficulty in getting up from the squatting position, followed by climbing upstairs, followed by downstairs, and proximal upper limb weakness in the form of difficulty in lifting heavy weights over the head, followed by difficulty in wearing the slippers and trippage of foot, indicating distal lower limb weakness. And current situation, she requires the support of one person in standing from squatting position as well as sitting position, and while climbing both upstairs and downstairs and walking, and in combing hair and wearing shirts, and in turning in bed, and in getting up from bed. However, she is able to mix food and write normally. At present, she is dependent on her family members for most of her activities of daily living, and she is restricted to home, and she is not working for the past 9 years. In negative history, there was no other history suggestive of abnormal muscle bulk, stiffness, thinning or twitching of muscles, cramps, diurnal variation, muscle pain, or weakness worsening with the exercise, and no history of fatigability, fluctuation, or grip releasing difficulty. No history of cardiac or respiratory symptoms suggestive of shortness of breath, swelling of legs, palpitation, or high colored urine. There was no history of sensory disturbances and no history of ocular or bulbar disturbances in the form of diplopia, drooping of eyelids, dysphagia, dysarthria, chewing or sucking difficulty, or visual or hearing disturbances. There was no history of autonomic disturbances and no history of joint pain, skin rash, or muscle pain. There was no history of any drug or medication intake or no history suggestive of thyroid dysfunction. Regarding the birth and developmental history, she was born out of a normal vaginal delivery, cried immediately after birth, and attained all her normal milestones. Past history, she had not a known case of diabetes, hypertension, or epilepsy. Personal history was normal. She had completed both the doses of COVID vaccination 1 year ago. Family history, she was born out of she was the third born child of a second-degree consanguineous marriage. She also has an elder brother who was affected with a similar illness with the age of onset around 15 years of age. And the current age of the elder brother, he is 2 years elder to her. He is around 31 years of age with the age of onset around 15 years, who had presented with similar complaints of weakness of all 4 limbs for 16 years, which was insidious in onset, gradually progressive, lower limb more than upper limb, proximal more than distal. However, he also needs support in getting up from sitting, squatting, and climbing stairs, but he is able to walk unassisted. Summary, she is a 29-year-old lady who has presented with insidious onset, gradually progressive, symmetrical, pure motor, lower limb more than upper limb, proximal more than distal, flaccid, non-fatigable quadriparesis with truncal weakness, with a positive family history of elder brother being affected with a similar illness. Since from this summary, the structure I would like to first localize is muscle. Since it's a pure motor element type of weakness, which was symmetrical and proximal more than distal, in which my differentials would be first being a limb girdle type of muscular dystrophy because of the distribution of weakness and the pattern of muscle involvement with the positive family history of two siblings being affected in the same generation. However, there are the things which factors which are against muscle myopathy. There was no history suggestive of abnormal thinning or abnormal muscle bulk. The second differential should be other dystrophies like Becker's muscular dystrophy or facioscapulohumeral dystrophy because of positive family history. However, being female involved here and there are no other cardiac or facial features, I would like to place it second. The third differential should be a congenital myopathy like an Emelin or central core myopathy because of the presence of positive family history. However, because of the factors against it are the late age of presentation with no other dysmorphic features like facial or skeletal or cardiac features. The other differentials in muscles would be mitochondrial and metabolic because of the positive family involvement. However, there were no other multi-system or cardiac involvement, and in metabolic there was no history of exercise-induced worsening of weakness or any myoglobinuria, myalgia, or respiratory weakness. The second structure I would like to localize is the anterior round cell. Again, because of the pure motor, flaccid, symmetrical, proximal more than distal, with a positive family history, with the onset around adolescence, with SMA being type 3 or type 4. However, there are from history-wise, there are no features suggestive of any cramps or fasciculations, and the neurogenic pattern of wasting more than weakness was not seen. The third structure I would like to localize is with the motor nerve plus or minus root. In this case, would be a pure motor CIDP. Since it's a pure motor flaccid quadriparesis, however, the factors against it, since both the siblings are affected in the same family, which is against an acquired disorder, and wasting neurogenic pattern of wasting more than weakness is not seen, and the course is also insidious in onset and gradually progressed. On examination, the patient was conscious and general examination was normal. Higher mental functions are normal. Regarding the cranial nerves, hearing and vision were normal. No facial weakness. Motor examination, bulk examination, as we can see here, now we will be presenting the pictures of both the siblings. He is the elder one, around 31 years of age, and she is around 29 years of age. As we can see here, there is generalized muscle wasting in the male, and from the posture we can see that the patient is standing with the knee extended, and preferably he is standing with the foot inverted, and there is no obvious wasting in the female because of subcutaneous fat deposition, and there was no scapular winging in both the siblings. And as we can see here there is atrophy of the upper fibers of trapezius as well as the posterior deltoid, which is more apparent in the male. And this was the sign we found in both the patients. As you can see, a prominent bulge in the biceps on contraction, thereby indicating an intramuscle selectivity of hypertrophy of select biceps fibers, thereby suggesting one of the possible differentials is a limb girdle muscular dystrophy. The other features which are more in favor of a myopathic disorder was the preserved EDP in both the patients. On further examination, tone was flaccid in all 4 limbs. Both the adductors and abductors in the upper limb were equally affected. However, the elbow flexion was more weak than the extension, again more in favor of a myopathic disorder. However, the distal power was normal. Coming to the lower limb examination, the hip flexion and extension were equally affected. However, the adductor was more weak than the abductor, and knee flexion and extension were equally affected. But here in the dorsiflexors were more weak compared to that of the plantar flexor. And the patient also had a history of splaying of hip, splaying of thigh, as we can see here, due to the selective adductor weakness. So you can see here, the patient is not able to flex her hip against gravity. And On dorsiflexion, plantar flexion appears to be good, but dorsiflexion is weak. And she also has difficulty in turning in the bed without support, and hip abductor is weak. She is not able to lift. But on lateral, with the gravity eliminated, she is able to do knee flexion and knee extension. On putting her in the prone position, she is also unable to do hip extension against gravity, as well as knee flexion. And she has severe difficulty in turning in the bed without support. On adduction testing, adduction was very weak. Abduction she was able to do at least with the lateral with the gravity eliminated, but adduction was weak. Coming to the reflex examination, so far all our features were in favor of myopathy, but all the reflexes were absent, even with reinforcement on gendrasics, but the plantar was flexor. Though the reflexes were absent, it does not essentially rule out a myopathic disorder. I would still like to place it. So coming to the gait examination, she had severe difficulty in getting up from the sitting position without support, so we had to recommend the standing position. And she required one person's support as well as the support of nearby walls, even for walking on a level ground. You can see she is walking with the knees hyperextended at the exaggerated lumbar lordosis and battling gait with the pelvis dropping on either side, with the foot dorsiflexor weakness also.
Hey, Raghavendra, play the next video.
Yes. Comparing the gait of her sister, as you can see here, she is able to get up with the support, and he is also having an exaggerated lumbar lordosis with hyperextended knee, and he is walking with an inverted foot with the bilateral waddling. Other system examination, test of fatigability was negative, Beaver signs was negative, and other system examination was normal except for exaggerated lumbar lordosis. Summary from examination, she is a 29-year-old lady who has presented with insidious onset, gradually progressive, pure motor, symmetrical, lower limb more than upper limb, proximal more than distal, adductor more than abductor, flaccid, non-fatigable quadriparesis with truncal weakness, with the biceps bulge and preserved EDB, with a positive family history of elder brother being affected with the similar illness. Given this summary, I would like to place muscle as my first localization. As previously mentioned, it's a pure motor.
Raghavendra,
Sir.
Somebody has raised a question that reflexes were not absent. Can you just show it once more? So they were actually absent, and that slight jerk you are seeing is because the vibrations going on from hammer. They were absent even on the gender axis. Yeah. Now we can proceed with the presentation.
Regarding the differential diagnosis, however, the areflexia was against the muscle. Regarding the differential diagnosis, the limb girdle pattern of involvement, the possible etiology being two siblings affected with a similar illness, suggestive of a genetic neurodegenerative disorder. I would like to place autosomal recessive limb girdle muscular dystrophy as my first, with the dyspareuropathy being my first, due to the presence of biceps lump. And there are no ankle contractures or calf hypertrophy. However, the areflexia was against it. Second differentials would be sarcoglycanopathy because of the presence of hip splaying due to more of adductor weakness than abductor weakness. Hip splaying can also be seen in dyspareuropathy. Factors against sarcoglycanopathy will include there was no obvious scapular winging or any calf hypertrophy or ankle contractures and no cardiac involvement. The third differentials would be a calpainopathy because of the presence of positive family history, but there was no scapular winging, calf hypertrophy or ankle contractions. Second differentials would be other muscular dystrophies like Becker's and EDMD, followed by facioscapulohumeral dystrophy because of the presence of family history. However, they were X-linked and no other features suggestive of scapular winging, Weaver's sign or asymmetry of involvement were there. Regarding the congenital myopathies, because of the later age of presentations and there was no dysmorphic features, I would like to place it later. The next structure would be an anterior rod cell due to again pure motor element symmetrical flaccid weakness with a positive family history with SMA. And more in favor was the presence of areflexia. However, there was no fasciculations and neurogenic pattern of wasting more than weakness was not seen. Third localization would be a motor nerve because of areflexia. However, there was no relapsing remitting course. It was an insidious onset progressive course with a positive family history. Investigations, routine investigations were within normal limits. The CK was elevated, was around 2123, suggestive of a dystrophic disorder, and urine myoglobin were negative and echo was normal. The NCS was within normal limits, thereby ruling out a neurogenic disorder. And ENG, there was no abnormal insertion or spontaneous activity. And on motor unit action potential assessment, you can see the normal to low amplitude, short duration, polyphasic MVPs with early recruitment, suggestive of a myopathy. And on interference pattern, there was early recruitment, and the interference pattern was almost full. Again, suggestive of myopathy. After the investigations, we did a genetic analysis of both the siblings, which turned out to be positive for dyspareuropathy, autosomal recessive limb girdle type 2, and both of them tested positive for dyspareuropathy. The genetics and the MRI of it, which will be dealt in the forthcoming sessions. Thank you.
If anyone has any questions, they can post it in the question QA session. And then I will pass the baton to Dr. Jairam, who can discuss the next case. Right, Dr. Vishnu? Is it okay?
Yeah. We are already 7 minutes late. So let's go on with the next case. We'll discuss the cases at the end.
Yeah. Anyone has question, they can definitely post it in the QA.
Good evening, everyone. I am S. Jairam, a senior resident from Department of Neurology, JIPMER. I will be presenting a case of 15-year young man, student, presented with chief complaints of weakness of both lower limb for 2 years, history of recurrent falls for 2 years, tremors of upper limb and lower limb for 2 years, and fasciculations and cramp for 2 years. So initially he had complaints of bilateral lower limb weakness for 2 years. Initially he started with difficulty in getting up from sitting position. He finds it difficult while using an Indian toilet. He needs support. He needs to support his hands to get up from squatting position, and he slumps while trying to sit down. And complaints of difficulty in climbing the stairs when he needs support of a railing to do so, especially in getting down the stairs. And he has difficulty in cycling for 2 years duration. He couldn't get on the cycle. He couldn't raise the leg, and he also had difficulty in pedaling, and he fell many times, especially when climbing or stopping it. So because of this, he changed to geared moped, but he cannot kickstart it also, and he needs his father's help to do so. So difficulty in getting onto the bike is there, and he also had difficulty in changing the gear, especially pushing it down, suggestive of plantar flexion weakness. However, there is no history of splaying of legs, or no history of slippage of slippers, no history of tripping, or no history of foot drop. Complaints of recurrent falls for 2 years duration, especially difficulty in walking with weight, more with a bucket of water carried over the shoulder. He also noticed tremulousness of both the legs and difficult to walk with bearing the weight. And he had buckling of the knees and he fell down. Difficulty in getting up without support, and he needs his mother's support to get up. And frequency of falls are 3 to 4 episodes per day, and mainly due to buckling. And falls occurred both in day as well as in night. And the last fall is 2 weeks ago, and the falls are more when descending the stairs. No history of pre-syncopal or seizure symptoms. No history of loss of consciousness, visual blackouts. No history of numbness, paresthesia. No history of wash basin sign or prayer sign. History of tremors for 2 years duration, which are fine, symmetrical, involving bilateral upper limb and the lower limb, more on stretching out the hands, and he spills the water if the glass is full. And due to this tremors, he had his handwriting changed. However, there is no history of smearing of food around the mouth, no history of head or voice tremor. No history of any ocular, bulbar or respiratory weakness, no history of neck, upper limb or truncal weakness, no history of thinning of muscles, no history of diurnal variation, fatigability, eye colored urine, tightness or looseness of limbs. History of twitching of muscles for 2 years over the bilateral thighs, which are intermittent, irregular, increased on physical exertion, not present in other areas, and no history of any organophosphate exposure. History of cramps in both the fingers were present, especially left more than right, relieved on stretching the fingers, which are very painful, lost for a few seconds, more with applying the clutch or the brake. No history of difficulty in releasing the objects or no relation to cold. No history suggestive of cognition, cranial nerve, sensory, or bladder and bowel involvement. Past history and personal history were normal, no positive findings. Family history was negative, except for family history was negative, but high consanguinity were seen in multiple generations. And no history of similar complaints among family members. So summary, 15-year-old male with 2-year history of insidious onset, gradually progressive, pure motor, symmetrical, LMN type, proximal lower limb weakness with cramps and infrequent fasciculations with recurrent falls due to buckling and symmetrical upper limb tremors. So from history, our first localization will be muscle because it is a proximal lower limb weakness and symmetrical and pure motor. So in the muscle, our differentials will be limb girdle muscle dystrophy and metabolic myopathy and congenital myopathy. The points which are against LGMD are the cramps and fasciculation because they are usually seen with the anterior on cell involvement. And metabolic myopathy, because he had proximal lower limb weakness and cramps. However, there is no exercise-induced myoglobinuria, myalgia, fasting hypoglycemia, rhabdomyolysis, or thinning of muscles. Since because of proximal lower limb weakness, congenital myopathy can be considered, but this is a late presentation. There is no contracture, facial weakness, or any keloid. Our second localization will be anterior onset, that is spinal muscular atrophy. Because of the proximal lower limb weakness, cramps, and presence of cramps and fasciculation. However, there is no significant wasting, which is usually seen. Wasting more than weakness is usually seen in SMA, but in this case, there is no significant wasting. And third localization will be nerve, because proximal lower limb weakness, no remission or relapse or no sensory features. So motor variant of CADP can be considered. And next localization, neuromuscular junction is possible, because limb girdle variant of congenital myasthenic syndrome can present with proximal lower limb weakness. However, there is no fatigability, no facial, bulbar, or ocular involvement, no diurnal variation or fluctuation. And the last localization will be spinal cord, due to possibility of segmental syrinx, can present with proximal lower limb weakness. However, there is no dissociative sensory loss or no bladder involvement. On examination, patient was conscious, oriented, afebrile, vitals were stable, no neurocutaneous markers, fundus was normal, no peripheral pigmentation. Nervous system examination, higher mental function and cranial nerve was normal. Motor examination, bulk was normal except for subtle wasting in the proximal lower limb, especially in the anterior bilateral symmetrical anterior compartment. Subtle wasting is there. No small muscle wasting, and tone was normal, no hypotonia. So upper limb, you can see it is normal, and there is no any focal lumps or bumps or any atrophy or wasting of the muscles. And the EDB is preserved. The motor examination, upper limb, there is a mild weakness, that is 4 minus, but in elbow extension is weak when compared to elbow flexion. However, wrist flexion and extension are normal. Coming to lower limb examination, hip flexion and hip abduction are grade 2 power, and hip extension and adduction is grade 3. And our knee extension is weak, that is more on left side when compared to right side. Left side it is grade 3 and right side it is 4 minus. And dorsiflexion is grade 5 and plantar flexion is grade 4. So here we can see that wrist and is normal, but he has subtle weakness in the shoulder abduction. However, he is able to turn on the bed as well as able to get up, so there is no trunkle or neck weakness. Coming to lower limb examination, here you can see dorsiflexion is normal. However, there is subtle weakness in the extensor hallucis longus, grade 2. Knee extension is weak. Left side it is 3 and right side it is 4 minus. And hip flexion is only grade 2. And hip abduction is also grade 2. So hip flexion and abduction are severely affected. And hip adduction power is grade 3. So hip flexion and abduction are grade 2 and hip adduction is grade 3. So this is opposite of the hip splaying sign. And with gravity eliminated, hip flexion is able to do. We have tested in all position, but due to shortage of time, only some videos we are able to upload. And he also has knee extension weakness. Left side it is grade 3 and right side it is 4 minus. And he also had bilateral symmetrical movements of hands. So symmetric, bilateral, symmetrical, frying tremors overlap with polymini-myoclonus. On examination of deep tendon reflexes, all the reflexes are 2+, and knee jerk which was initially absent, but with reinforcement with Jurassic it was 1+. No percussion myotonia. Here we can see examination of deep tendon reflexes. All the reflexes were preserved.
So I would request everyone to see the reflexes carefully. All the reflexes were clearly preserved. These were grade 2. And the knee reflex was slightly diminished. We can see here. Please see the reflexes carefully.
Knee reflex is absent initially. Even ankle jerk is preserved.
Ankle is present, why you want to reinforce it?
Plantars or flexors.
You need to reinforce it, what is absent. You want to reinforce the knee.
So knee jerk was initially absent, but with reinforcement, Jurassic maneuver
1, 2, 3.
is 1+.
1, 2, 3. 1, 2, 3. Okay.
And here you can see there is exaggerated lumbar lordosis. However, there is no wigging of scapula or no calf hypertrophy. And Gower sign was positive in this patient due to proximal lower limb weakness. Other examination, forearm abduction test was negative. Beaver sign was negative. Fasciculations are present in the bilateral thigh region. No sensory, cerebellar or extrapyramidal signs. And gait you can see. While getting up, there is abductor, bilateral hip abduction is weakness. So there is a knocking of knees and increased exaggerated adduction. However, is able to walk. And there is subtle waddling gait.
Curiously, this is just opposite of splaying of splaying.
It's opposite of splaying because there is a weakness
splaying.
of hip flexion and abduction, and
So
increased
the knee
adduction
knocks,
due to abductor weakness.
So knees were actually knocking when he gets up. Can you just show it once again? Just the initial phase. When he gets up, just the knees are knocking with each other.
Here we can see there is abductor weakness and both the knees are coming together. So summary, after examination, the 15-year-old male for symptomatic for 2 years duration, insidious onset, gradually progressive, symmetric, pure motor element quadriparesis, the proximal more than distal and lower limb more than upper limb weakness with reduced knee jerk, and other deep tendon reflexes were normal with fasciculations, fine tremors and polymini-myoclonus of upper limb, and Gower sign was positive and exaggerated lumbar lordosis was present. So from this, our localization was muscle. First localization was muscle due to pattern of muscle involvement and the presence of reflexes. And second localization was anterior onset because of proximal lower limb weakness, cramps and fasciculation. And third was nerve because of proximal lower limb symmetrical weakness. So still our first localization remains muscle. because it is a symmetrical by proximal lower limb weakness, pattern involvement, and reflexes were preserved, and there is no EDB wasting. EDB is preserved. The things which are against LGMD are cramps and fasciculations, no lumps and bumps, and no selectivity. However, this will be discussed later. And metabolic myopathy is still considered because of proximal lower limb weakness, preserved reflexes, and cramps. And congenital myopathy is still a possibility, but it is a late presentation. And second localization will be anterior onset, and the spinal muscular atrophy will be differential because proximal lower limb weakness with cramps and fasciculation and polymini myoclonus is present in examination. However, there is no significant wasting, and reflexes were preserved, and EDB is preserved. So these are the points which are against spinal muscular atrophy. And motor variant of CIDP can be present because of proximal lower limb weakness. However, there is no loss of reflexes. There is reflexes are preserved, no remission or relapse. And the limb girdle variant of congenital myasthenic syndrome is another possibility due to proximal lower limb weakness, preserved reflexes, and fatigability. And segmental syrinx can be considered, but there is no bladder or dissociative sensory loss. So it will be the lost differential. So from this, still our first localization is muscle, that is LGMD or metabolic. And second will be anterior onset, that is spinal muscular atrophy due to proximal lower limb weakness, cramps, and fasciculation. The only odd point is there is no significant wasting, and reflexes are preserved, and EDB is preserved. So all the investigations were normal, but the CK total was elevated, that is 827. And EMG showed active denervation with fibrillation.
Just pause it once. Just go to the previous slide. Previous. Yeah, so with this backdrop, like with reflexes preserved, pattern weakness, but with odd findings of this fasciculations and all those things, we went ahead with the EMG. So somebody asked the question why EMG is important. Now it will depict. So here two of the major differentials were muscle disorder or entry-onset disorder. So now what happens in the EMG we will see and how it affects the course of illness. So with this backdrop, we went ahead with the EMG. Yeah, proceed, show the EMG.
So here we can see fibrillations.
You can see fibrillation and positive sharp waves here.
Fibrillation
yeah?
and positive sharp waves.
So fine, go to the next.
So this is showing high amplitude, long duration, polyphasic MUAP with poor recruitment, suggestive of neurogenic pattern. This was seen in all the muscles, that is right side at vastus lateralis and tibialis anterior, and also the lumbar paraspinal muscles, all showed a neurogenic pattern with poor recruitment. So after considering the clinical picture and the EMG suggestive of neurogenic pattern,
You have to show
we
the
considered
interference pattern. Interference pattern. Next slide.
that's a picket fence pattern. Then
So this pattern of EMG was present in all the muscles we sampled, and not a single muscle showed a myopathic pattern of short polyphasic duration or early recruitment. Because some of the muscle diseases can show neurogenic pattern, but this large amplitude and these are not mentioned. Only few P's and fibrillations have been mentioned in the literature. And this type of pattern in all the muscles indicated a neurogenic involvement. Yeah, proceed.
so after this clinical history and EMG suggestive of neurogenic pattern in all the muscles, we planned for sending genetic analysis. That is, one is SMA panel, and second is whole exome sequencing for limb girdle muscle dystrophy. But since the patient was not affordable for whole exome sequencing, so initially we sent for SMA panel, and we thought if required sequentially, we will send for whole exome sequencing. To our surprise, SMA SMA panel turned to be positive. That is, there is a homozygous deletion in SMN1 and duplication of SMN2 gene. And we also done muscle biopsy for this patient, which is suggestive of neurogenic atrophy, suggestive of anterior onset disease with secondary myopathic changes. So in our case scenario, in our clinical case, the odd points are, one is the preserved reflexes, and second thing is elevated CK levels, and third is the neurogenic pattern. So initially our approach was like before EMG, our approach was like limb girdle muscle dystrophy due to myopathy. However, there is no lumps or bumps or no selectivity within the muscle, but the presence of fasciculations, cramps, and the neurogenic pattern in the EMG made us think of SMA. So SMA can spinal muscular atrophy. There is a deletion, homozygous deletion of the SMN1, and there is a duplication of the SMN2. So SMN1 contributes majority, and SMN2 contributes only 15% of the total. So if there is a deletion of this one and SMN2 duplication, the number of SMN2 repeats will be inversely proportional to the severity of the symptoms. So our patients fits into SMA type 3B, that is between 3 to 21 years. And we reviewed the literature because of the presence of preserved reflex, and there are also gene therapy available. Either it can be adeno-associated vector related to SMN1, or drugs which interfere with mRNA splicing, that is nusinersen and risdiplam, which interfere with SMN2 gene. So our patient is not affordable for it, but we are planning from the department to indent it. And the first odd point of our case scenario is the presence of reflexes in SMA. So we reviewed the literature, and we saw that usually the reflexes are absent and significant wasting is there in SMA. But the presence of reflexes can be against SMA, but does not completely rule out SMA. So in the early stage of SMA, there can be a transient hyperreflexia. So in our case, reflexes were normal and it is preserved. So it can be an early presentation of an SMA where sometimes the reflexes can be preserved even in SMA. And this is another article from Indian Journal of Pediatrics. Here they have mentioned that usually air reflexia occurs due to anterior onset degeneration, but the partial anterior onset function at early stages can present with preserved reflexes. And second thing is increased CK levels. So usually CK levels are elevated in myopathy, but in SMA also up to 10 times the upper limit of normal, the creatine kinase levels can be elevated. So till 2000 it can be elevated. In our case, it is 827. And there can be neurogenic pattern in muscle diseases, especially in chronic myopathies and inflammatory myopathies. So brisk dependent reflexes
and certain disorders like FSHD are also known to, certain limb girdle muscular dystrophy is also known to, and advanced disease LGMDs can also have somewhat neurogenic findings. But large polyphasic potential are not the feature. You will generally find positive sharp flows and fibrillations.
So brisk deep tendon reflexes and lower motor neuron disorder indicate motor neuron hyperexcitability before not motor neuron degeneration. And the progression of deep tendon reflex loss follows a specific pattern that is proximal to distal, lower limb to upper limb. Quadriceps tendon areflexia occurs first, and later Achilles and upper limb reflexes, as in our case. And this has been found in the mouse model also. So early at the proximal hind limb, followed by distal hind limb muscles. So preferential and early loss of motor unit function controlling a greater number of muscle fibers has been proposed as an underlying mechanism. So take home points, 2 points. So first is from the clinical scenario, we have to keep our differential diagnosis and localization broad. So before narrowing it down, we have to think it broad. So muscle and anterior onset, we have keep it in our differential diagnosis from the first. And after EMG, whenever we find a case of like even when myopathy features are present, if we see some atypical features like there is no hypertrophy of muscles and polymini myoclonus, fasciculation, cramps, and EMG suggestive of neurogenic pattern in all the muscles, SMA should be suspected as it is a potentially treatable condition. Thank you. I thank the organizers and the professors for giving me this opportunity. Now I invite Dr. Vaibhav sir for the comments and further discussion on approach to LGMDs.
So, Dr. Vishnu, you want to take any comments from the audience or something, or any comments from your side till now? Then I will take
Yeah,
the approach.
it's two very, thank you, sir, and thank you both Raghavendra and Jairam. So, two interesting cases presented. So,
you can take 1 or 2 questions, or you want to comment, because I will cover 5-10 minutes for you. Don't worry.
Yeah. So, so in the question answer session, so some of them have most of the thing. I think you have remembered most of the questions you have answered. My comments over the case, first thing, I mean, Dr. Nalini is also there. We'll ask Madam also. In the first case, I think it was you discussed more for the teaching as a teaching case, probably for the residents as such. But it is a straightforward case of dysfunctionality, right? It's a family history positive.
Yeah.
Both the bilateral, I mean, there is so much of a selectivity of the muscle involved. The biceps lump is there. CK is elevated. So,
but DTR is absent.
Yeah. So in this case, I think Dr. Nalini is there, and Madam is still joined. I think she's there.
Yeah, I'm there, Vishnu.
Madam, I will ask
Good
you
evening,
the
madam.
controversial
Good
question.
evening.
So if you are seeing this patient in the OPD, will you do EMG or will you directly go to the genetics? The first
Madam
case.
will not.
See, that's a tricky thing. If you want students to learn. See, if I saw this patient, I mean, with all the experience, when he walks into the OPD, I would make a diagnosis of dysphalinopathy, proximodistal form, because he has waddling gait and distal weakness. And we call this as in fact, we've just submitted, this is a classical dysferlin gait. And the dysferlin
Yes.
gait consists of the forefoot and the hind foot almost touching the floor simultaneously, with bit of the inversion of the foot, as both these
Okay.
patients had inversion. Then as they walk, you
Ma'am.
see that the extensor hallucis goes into extension, whereas the flexor digitorum overacts, because that is more stronger than the extensor digitorum. So
Ma'am,
this is
thank you so much
actually
for
long
that.
back. Right, yes. So it's a classical dysferlin gait.
Yeah,
And
thank you so
muscle
much for
MRI
explaining that.
also helps.
I was not able to explain that inward, why he's walking on the edge of the outer foot. I couldn't explain that.
A bit of the, no,
maybe I
the
missed
everters are weaker than the inverters there. And we have done muscle MRI in 40 patients and shown that the flexor hallucis and the flexor
Okay.
digitorum is much better preserved, and extensor hallucis is slightly stronger than the flexor hallucis.
So
So
like
this, you
tiptoe
saw
walking,
that
we
it's
can have
not
edge
like the
walking.
usual
Okay.
LGMD gait. So this of course, I would do a CK. CK is elevated, and the next step is same day the patient gets a blood drawn for genetics, and then they go home and come back after 1.5 months for the genetic report. So, of course, this is the approach that we have now following for the last 10 years in genetics came up. So,
And
of course,
interestingly, Madam, the
EM,
one thing you also told was the pseudoplantar effect that we see sometimes in dysferlin, the toe going
yes.
upwards. That is also when a patient walks up and comes with a waddling gait and with that kind of thing, you can. That is one of the few features when we don't see that in most of the other muscular dystrophies, even with the distal weakness. So something that is very peculiar to dysferlin also. And thank you, ma'am. So regarding the second case, it was even more interesting. Something of this one.
So Dr. Vishnu, the idea was to keep a typical case and an atypical case.
I know. No, I'm not
idea.
saying that it was. I mean, for a resident teaching purpose, that was a good case to show. So we all learned in the same route. So now we are sitting in 2021, but when we all learned, we all gone through the same.
So in that case, EMG was Turner completely, like it was completely neurogenic and everything.
Yeah. So the second case also something which the preserved reflexes in SMA. We see all sort of variants in SMA, right? We see EDB hypertrophy in SMA. We have seen calf hypertrophies in SMAs. We see even angle reflexes preserved in SMA. So there's a lot of things. These are all unusual variants that we see in a case of spinal muscular atrophy. So the clinching point usually is the fasciculation. So the moment you see a fasciculation, it's proximal muscle weakness.
Yes.
I think
because surprisingly, Dr. Vishnu, all the neurogenic patterns have been explained, but in muscular dystrophies, fasciculations have not been described. I couldn't find the fasciculation here.
Yeah, I mean, I was just texting with Divak. So I said that when we see, if somebody we see a case like this in OPD, next time somebody will see a case, the first thing we'll do is an SMA MLPA. So first go for that, and then we think about anything else if it comes up to be negative in that case. So I think that's the two interesting cases. I think we'll move ahead because of lack of time. I think I invite Dr. Vaibhav to look at the approach to the limb-girdle muscular dystrophies, how give an overview of it.
Yeah, my slides are visible? And am I audible?
Yes, both. Please go ahead.
Thank you. So thank you for so much for inviting us. I will straight away jump into the discussion. I will just start with the overview. Of that, I will discuss nomenclature and classification, approach and clinical patterns. First is the new nomenclature given by ANMC 2017. The LGMD reached Z and there was no further to go. And there were some problems with previous classification. So the European Consortium in 2017 replaced the older classification. They replaced LGMD1 with LGMD-D and LGMD2 with LGMD-R. So D is dominant and R is recessive. Similarly, there were further changes. Many of the disorders were removed, like in the dominant types, BEACH, beach mnemonic, you can remember, were removed. So LGMD1D, it starts as a limb-girdle muscular dystrophy. Beach is now no longer considered limb-girdle muscular dystrophies. So LGMD1D is now known as LGMD-D1, dominant 1, dominant 2, dominant 3, dominant 4. And this has to be followed by the gene name. Similarly, in the autosomal recessive pattern, R and VWXY, you can remove R for removed, R removed, VWXY removed. These no longer classified as limb-girdle muscular dystrophies. And there was one more problem with the previous classification, that alpha, beta, gamma, delta were not arranged in the proper manner. They were gamma, alpha, beta, delta. They have been arranged to the properly alpha, beta, gamma, delta now. So there are 3, 4, 5, 6. So now in total, there are 21 recessive LGMDs. So now we will come to the approach. Now we have seen today 2 cases, one LGMD with reflexes loss and second LGMD SMA with reflexes preserved. And how to approach these disorders. Although my topic title today is approach to limb-girdle muscular dystrophy, but I will take an approach to neuromuscular approach as such. What helps? So our idea is, now today my topic will be discussion only in the lower motor neuron disease. I will not discuss the upper motor neuron disease. So lower motor neuron disorders are anterior horn cell till the muscle. What helps? So usually the disease we are discussing here, neurodegenerative disease, slow, age of onset is earlier, although it's variable. Sex, it is equal, doesn't help. But in certain diseases like dystrophins, it helps. Dystrophinopathies, it helps. Familial history is a very good clue if you get, but in most of the cases, family history is not present. Course and progression is usually slow, broiling, insidious. And usually symmetry is preserved. It is the overall course is symmetrical, but however, asymmetrical disease is also known. Key features of LMN disorders are weakness, wasting, fasciculations, and hypotonia. So this is the first disorder. These are the first things we have to see and try to classify on the basis of our history and examination and bring the disorder to lower motor neuron disorders. Once we have done this, we have to decide whether it is a muscle disorder or not, which is the topic of the day. One of the findings while deciding on the lower motor disorder is whether it's a muscle disorder or not, is that we often forget to take into account the selectivity. So I will just take the selectivity part, and I will insist resident to not forget this while answering in the Viva. The selectivity is of 2 types. One is between the muscles and within the muscles. Okay. So selectivity means selective involvement between the muscles and within the muscles. None of the neuromuscular disorder is totally non-selective, like all the muscles involved at a single time. Between the muscles, it's totally non-sensitive. Even when you say generalized myasthenia gravis, you will have some ocular involvement, some proximal involvement, one muscle involved and other muscle not being involved. Similarly, in the type 3 and type 4, we saw that proximal is more involved, and Dr. Jairam also gave an explanation for that. And similarly, all the disorders, congenital muscular dystrophies and everything, between the muscle selectivity is a rule. However, within the muscle selectivity is a characteristic of muscle diseases only. That is not usually found in other disorders. So let us see what do we mean by selectivity within the muscle. See the first diagram, of which is the case 1 of our presentation. You can see so many lumps and bumps, and even in the advanced disease. So it's gross wasting of all the muscles, but still you can see lumps and bumps. Second is a case of spinomuscular atrophy. You can see no lumps and bumps. And third is a case of FSHD, which I have taken from literature. This is called as polyhill sign. And you can see so many lumps and bumps. So these lumps and bumps are characteristic. Once you see this case, as we see in the first case, we saw a bicep sign, bicep hypertrophy within the bicep hypertrophy. Although we did not find there's a diamond sign, these signs, if you find, this is very, very characteristic of muscle disorder, and more specific of limb girdle muscular dystrophy. To some degree, they may be found in congenital muscular dystrophies also. So this is a very strong indicator of muscle disorders, and that muscle disorders also limb girdle muscular dystrophy and congenital muscular dystrophies. With this in mind, we proceed with the further process. So where did the case 1 stood in our discussion? Case 1 was very classical, and I don't think anyone would be having any confusion that it was a muscle case, and in that also LGMD or congenital muscular dystrophies. Why so? Why were we so sure from the muscle only? Because it was a pure motor involvement, chronic insidious course with selectivity within the muscles and preserved reflexes. In our case, the only finding was the reflexes were absent in case 1. So how do we explain that? It can happen in advanced muscle diseases where reflexes become absent, because ultimately spindles are of the muscles are also affected. However, case 2 was a bit more tricky because it has proximal involvement with preserved reflexes. So it misguided us, that preserved reflexes were misguided us towards the muscle disorder till end, and it became more clearer to the LGMD. But as we see more and more cases, the earlier presentation of SMA, as Dr. Jairam explained, with our case was only 2 years old. So where there the reflexes can be preserved. So rarely, and especially in the early in the course SMA, the reflexes can be preserved. Congenital myasthenic CMS and CIDP motor variants were unlikely in this case, but we need to keep them in differentials, and CIDP was definitely ruled out by the nerve conduction study and also clinically because of all the no lapsing limiting and very long standing course. CMA, there was no fluctuation fatigue. So once we have removed this red herrings and we come down to myopathy, it can be either acquired or it can be hereditary. In this scenario, acquired inflammatory myopathies. By acquired disorder, we mean inflammatory myopathies. These are usually subacute onset and such prolonged course are not there. But it may lead to sometime confusion when the course is very prolonged. However, such a scenario most often indicates a hereditary disorders. By hereditary, we mean neurodegenerative disorders. And in neurodegenerative disorders, we have to exclude, before lending down to limb girdle muscular dystrophy, we have to exclude 4 basic disorders which are red flags. So what are the red flags to the diagnosis of limb girdle muscular dystrophies? One is presence of any myotonia, stiffness history, or hypertrophied muscle. This indicates myotonia. If you have got lot of cramps, dark urine, second wind phenomena, these were not present in our case, although few cramps can be present in spinal muscular dystrophy, which are present in the first case in the distal cramps. But in metabolic disorders, the cramps will be very severe. So metabolic was less likely. And in the mitochondrial multisystem involvement usually will be there, and metal inheritance can be found. So these were less likely in these cases. And in the congenital muscular dystrophies, the other problems like facial dysmorphism, spinal deformities, contractures, and by contracture we mean multiple contractures, involvement of fingers, involvement of elbows, in addition to the ankle, you can find. But the most important feature is usually they are early presenting, except in the few which can very rarely they can present in can be adult onset, like especially the Nemelin myopathy, but most are early onset. So our case were late onset. So that made congenital muscular dystrophies less likely. With this, we come down to the diagnosis of limb girdle muscular dystrophies. Limb girdle muscular dystrophies are known for their patterned involvement. So what are the various patterns? The various patterns are shown in these diagrams, which in which our case 1 and case 2 both had a humero, this limb girdle involvement, or proximal lower limb and proximal upper limb involvement. The other patterns are obviously the one of the Duchenne and Becker. I think it would have been better to classify Duchenne and Becker as LGMD type X, but it's not how it has been classified. So it has been treated as separate disease, which also has similar distribution. But in our cases, females were also involved, and the presentation was not like Duchenne. Becker, maybe to a certain degree. There was no facial involvement, there was no ocular involvement, but a large number of cases of FSHD can be facial sparing when the things can become confusing. But in that case, Beaver signs is usually positive, which was negative in both the cases. It was not a distal involvement in our case. If we go to the second step, which is the inheritance pattern, both the trees shows a autosomal recessive pattern or a sporadic pattern. So we will take it for now autosomal recessive pattern. Sporadically, it can be anything. We cannot say it's autosomal dominant or autosomal recessive. And for the sake of completion, we will discuss both autosomal dominant and autosomal proximal. So first, we will discuss the autosomal dominant disorders, which are now known as LGMD type D. So if you find a foot drop, cardiorespiratory involvement in pseudomyotonic discharges in EMG, these were not present in our cases. You will suspect LGMD D1 or myelin or desminopathies, which were previously classified but now no longer classified as LGMD type D, LGMDs. If you find rippling muscles or cramps, you will suspect capillopathies. If you suspect humeroperoneal muscle wasting and contractures, multiple contractures, cardiomyopathy, rigid disease, respiratory problems, severe disorders, you will suspect laminopathies and amyotrophic myotonic dystrophy, autosomal dominant type 2. And then there is a Velocin myopathy, which has multiple other features like inflammatory infusion body myositis, dementia, and Paget's disorders. They can have myotonic discharges on EMG also, and both proximal plus distal involvement are possible, but this was not presenting in our case. With this in mind, with this pattern and with this classification, you will proceed with genetics, if needed biopsy, the completion, and MRI. Most of the cases, we don't go in for the biopsies unless there is some confusion. Genetics and MRI makes the matter clear, which will be more detailed in discussed in more detail by Dr. Rajeshwari. So now we come to the topic of the today, where we will find that we will keep in the LGMD and autosomal recessive pattern, which are now known as LGMD-R. If you find scapular winging, which was not present in our case, contractures, which were not present in the case, here we are talking specifically of the ankle contracture and toe walking as an inaugural feature. With lumbar lordosis, abdominal hernia, you can be quite sure that you are handling calpanopathy. Calpanopathy is one of the common LGMDs in Indian scenario, so you must know these features. What we found in our case was proximal muscle wasting with calf atrophy and gastrocnemius wasting. He couldn't stand in the toes. So dysphalanopathy can have two patterns, proximal pattern and distal pattern. If you find a similar pattern which is highly asymmetrical and very slow involvement, then you can find you can suspect an anactinopathy. For remembering purpose, you can remember A for asymmetry. So these are now being more and more diagnosed. And then comes one of the common scenarios, which are sarcoidoglobinopathies. Here you can find a massive calf hypertrophy, scapular winging, and these both were not present in our cases. One of the very important key features to remember is these disorders can have cardiorespiratory involvement. So this sarcoglycanopathy and fukutin-related myopathies will need regular interval cardiac screenings. And if you find abnormalities, they may need a defibrillator cardiac intervention. So otherwise they can, you can have sudden death on your hands. And then comes foot drop. If foot drop is with weak quadriceps, severely weak quadriceps, distal wasting predominant, then you are facing tendinopathies. And if quadricep is preserved till late, then you are facing GNE myopathy. So in our cases, quadricep was clearly involved and there was a buckling sign present. So GNE myopathy was ruled out much earlier. So this is also one of the commonly diagnosed nowadays. So we are finding more and more cases. These are to be followed by the genetics, biopsy, and MRI. Biopsy to be done only where there is a diagnostic confusion. Otherwise, genetics and MRI studies are very helpful and they are enough. So just to give you some pictorial essay, very massive hypertrophy of calf, DMD, Becker's, LGMD, especially sarcoglycanopathies. In that also the gamma 1, and then LGMD R9 fucotone related myopathies. These three you have to suspect. If you find severe atrophy, then LGMD dysphalanopathy, as it was present in our case, the calf hypertrophy was not present, or severe atrophy is present. And then bulge in the bicep sign, which is characteristic of dysphalanopathy, then diamond sign, which is characteristic of dysphalanopathy. This was not present in our case. And this is difficult to elicit because you have to make the patient partially contract the quadricep, which are weak. So this is a bit difficult to analyze. And then this was a dysphalanopathy sign found in dysphalanopathy, where you find a calf head on the trophy sign. You have to see this is the calf head on the trophy side, each side. One. So this was not present in our case of dysphalanopathy. And this is the classical valley sign from where all the saga started, where the posterior fold is classically wasted. So this is all about selective muscle wasting within the muscles. And this is the polyhill signs or FSHD, where you can see so many lump and bumps. And additionally, you can find the Popeye sign where the forearm is spared in this case. So I will take a stop here, and if any questions or any comments are there, we can proceed. The key findings of our cases and are this: the take-home messages are phenotypical patterns help. You should have these all patterns with you in the OPD with charts so that you can try to make diagnosis. All the tests have their own significance. Biopsy should be done at the end, but atypical cases are possible. You can get many variations, as Dr. Vishnu also stressed. You can get result, but they are all rare. First, go for the typical patterns and then try to identify the atypical patterns. So that's my take-home messages. And if a few questions we can take, I have saved around 10 minutes of your time. So if any one or two comments are there, you can take, and then we will proceed with the MRI and the genetic approach. Thank you.
Thank you, sir. So let's thank for the great overview. Let's see if you have any questions referring to the thing is not there, but I'll just make one comment basically on the LGMD classification. You were told that the DMD and BMD should be considered as an LGMDX. Actually, so I mean, but technically, all this BMD and DMD should be an LGMD. But I think the LGMD classification, they have kept the LGMDX as in case any future X-linked LGMD will ever be discovered. And then other than the BMD or DMD, I think that it has been kept to be labeled as LGMDX. I don't know, Dr. Nalini can confirm if that's what I remember. So I don't, I'm not sure. So something of that sort, they have kept it so that in case in future an X-link is discovered or not, that's something which should be there. And I think we will just go ahead with the next talk so that we can take both LGMD.
There is one question that is in the Dr. Sujana has asked. In the second case, knee involvement was asymmetrical, cramp specification were present. So it actually reflexes present is taken as a hardcore sign. When reflex becomes present, that is a hardcore positive sign. SMA should be in differential But I don't know how it will go if you keep SMA as the first differential in presence of very good. But now we can keep, when we say that early 1 or 2 years it can be present. That is the thing. When slight asymmetry can be present in all the muscle disorders, even in the FSHD can be asymmetrical. LGMD is all slight asymmetry is okay. On the basis of single asymmetry, you cannot just change it to anterior onset disorder. Asymmetry is not a hard sign. Yeah.
Okay, then somebody else, if you want to take further questions, there's some couple of questions. Is there any grading for neck and trunk muscle weakness?
Yeah, neck we can grade normally.
It can
like
be graded. Yeah, it's still
grade
there.
3 grade.
I think it is there in the grading of a neck can be done. Trunk also technically can be done.
Only small muscles of hands are not graded because gravity doesn't apply. Otherwise, this can be graded as usual MRC grading only.
Okay, then next finally is, does GNA myopathy have early EDB atrophy?
I'm not aware. I'm not aware of this answer. I need to see.
Anyway, we will not see a EDB
Anyway.
hypertrophy at least. I don't think so. You'll see.
Yeah, definitely.
And then on the see. Okay, though, if any more questions, are there anyone in the panel wants to ask any questions? If it's not there, I think then we can move to the last and the most interesting talk from Dr. Rajeshwari on the genetics of LGMD, which is the flavor of the times. So over to you, Dr. Rajeshwari.
Thank you. Can you see my slide and can you hear me?
Yeah, welcome, Dr. Aishwarya. You can see. Can you make it slide presentation?
Yeah. Right. Thank you, Dr. Vishnu. So I will move quickly to from where Dr. Vaibhav left off. That is a clinical approach to a patient with element type of proximal muscle weakness. And I will be talking mostly about genetic testing and muscle MRI, and we'll be going back and forth between these two areas using our cases as examples. So both the AN as well as the ANM, they advocate for the use of genetic diagnosis for all such patients, especially those with degenerative neuromuscular disorders. And this is because it produces a sense of closure, and further it allows us to streamline our future management, and it also informs genetic counseling. To this extent, the AN and NM have come out with an algorithm on how to approach genetic testing. They suggest that you use clinical features along with some information regarding their genetic inheritance to inform your genetic testing. But it's easier said than done. And the problems are basically twofold. One is the relationship between the genotype and the phenotype is very complex. And it is, and this is an example of heterogeneity. The second problem is the rate at which genetic information and the genetic testing and technology associated with it is expanding. And this has left us with so many choices that for a clinician sitting in the neuromuscular clinic, it is often difficult to decide which of these tests should I order for my patient. So what can we do then? So these guidelines themselves, they provide an out or an assistance. They suggest that you identify distinguishing features. You look for specific EMG features, and this is the area where muscle MRI also helps. So basically, muscle MRI in this setting can be used to support your clinical diagnosis. It provides a detailed information regarding the underlying patterns of involvement, and possibly better than a clinical examination, because it provides information regarding subclinical involvement. The differential pattern can allow us to identify various pathologies and thus constrain the differential diagnosis. And this is very important when we are going to perform genetic testing. Other uses of muscle MRI includes establishing pathogenicity of variants of unknown significance and doing objective long-term follow-up, longitudinal follow-up of these patients, and to finally guide muscle biopsy. Muscle biopsy, usually we talk about 3 sequences, the T1 sequence and the T2 sequence, which are the usual sequences. In addition, we also perform a stir sequence, which is basically a fat suppress sequence, and that enhances but basically suppresses the fascia and enhances intramuscular pathology. Another consideration when we perform a muscle MRI is whether we want, what is the field of view we want. For focal disorders, such as say a muscle abscess, a small field of view is probably sufficient. But when we are talking about degenerative disorders like muscular dystrophies or SMAs, we need a large field of view, preferably of the entire body on both sides. As far as analysis or assessment of these muscle MRI is concerned, most places we go with a qualitative assessment of the study, and this is what we are going to do over the next few minutes. Another method is to do a quantitative. These are specialized sequences, such as the Dixon sequence. Each provider has actually a slightly different name for it, but essentially what these sequences do is that they quantitate the amount of fat within a given section. The third possibility is semi-quantitative. This is the Mercury scaling system, which I have provided. There are other such scaling systems, and these are becoming increasingly popular with people who are following up patients with muscular dystrophies as well as SMAs to demonstrate their patterns of involvement on muscle MRI. So muscle MRI, abnormalities on muscle MRI can be many, but usually 4 important ones are there. One is abnormal anatomy and normal signal intensity, as the name implies. Usually it's just an anatomical anomaly. Here in this case, it's a third head of a gastrocnemius and an accessory soleus. Intramuscular masses such as abscesses or tumors or even neurocysticercosis can be seen on muscle MRI. Third, and of more interest to us, is probably presence of edema or inflammation. These are usually seen as T2 hyperintense lesion and are commonly seen in inflammatory myopathies and rhabdomyolysis. Of relevance to the cases that we are discussing here is the presence of atrophy and fatty infiltration. These are best seen in both in T1 weighted sequences, where you can see that the normal feathery appearance of the muscle is replaced, and there is hyperintense signals coming from fat and fibrous tissue involvement. And we can also identify atrophy and eventually loss of the muscle as well. So coming to the muscle MRI of our patients, unfortunately, we do not have all the sections for all the patients. I'm only going to present a few selected sections from both the patients. So this is paraspinal muscles. This is just to see the anatomy of the paraspinal muscles. So here is the patient. This is the boy with the flaccid weakness but preserved reflexes. So this shows that there is a loss of bilateral psoas, as you can see here. This is a very big muscle, and this correlates with its difficulty in flexing his hips. The multifidus muscle on either side of the spine appears normal, but the erectus spinae is again showing significant fatty infiltration and signal changes. The quadratus lumborum appears normal, and the abdominal muscles also essentially look normal. As far as the pelvic girdle is concerned, here again, we have only illustrative sections from our first patient. Here you can see the gluteus maximus is showing some signal changes. Although it's not very clear when we see sequentially, these signal changes are much more prominent. There is on this side, one second. This is your gluteus medius that is also showing signal changes, and somewhere just under it is the gluteus minimus, which is also showing signal changes. Of note here in this particular section is that the tensor fascia lata, which is over here, appears relatively preserved, and the iliacus also shows significant atrophy and significant signal changes that is consistent with his marked difficulty in flexing his hips. Here, when we come to the thigh level MRIs, this I'm able to show both the patients. This is the boy with preserved reflexes, and this is the lady with the absent reflexes. So the boy with the preserved reflexes, as you can see, there is again diffuse involvement. There is involvement of the anterior compartment of the thigh. There is involvement of the posterior compartment of the thigh, but there is some relative sparing of the medial compartment, particularly the adductor longus and the gracilis muscle. Both of them appear to be relatively preserved. As far as the lady was concerned, again, it shows diffuse involvement, and because of the advanced nature of the disease, we are not able to make out almost any of the anterior group muscles or the medial or the posterior group of muscles. However, we can see that the sartorius, the gracilis, and possibly the rectus femoris appears relatively less involved.
Rajeshwari,
far as the legs are concerned, here
Rajeshwari,
again, Yes,
Rajeshwari,
sir.
can you just
Yes,
go to
sir.
the previous slide once? Yeah, and to the note, to the note here is case 1 is 15 to 20 years old presentation of limb girdle muscular dystrophy, and type case 2 is just 2 years old. So the extent of involvement is like so different. Am I right in saying that?
Yes, sir. And also
Yeah.
another thing of
So it is
that
just
I also found
case-
interesting was that,
Yeah.
when we saw the patient clinically, we thought there was no atrophy, but most of the atrophy has been masked by this marked proliferation of subcutaneous fatty tissue.
Yes.
And that also can be made out only by performing such an imaging.
Yes, and many of the muscles which we can't test individually by in examinations, we can show the sparing or involvement here. And again, coming to the first point, case 1 is 15 years old, 15 years of presentation, and case 2 is just 2 years of SMA. Case 1 has absent reflexes and case 2
Sir,
reflexes.
no, that is not the case. One is our 15-year-old boy with preserved reflexes, and case 2 is the lady with absent reflexes. Case 1 has a disease duration of 2 years, and case 2 has a disease duration of 15 years.
Okay, these both are LGMDs. Or
No,
one is
sir.
SMA.
This is our patient.
Yeah, this is which one is LGMD and which one is SMA?
Case 2 is the LGMD, case 1 is the SMA.
Okay, it's the other way around. Okay, fine, proceed.
So coming to the legs, again, I'm unable to show you the MRI of the patient with the suspected SMA. Instead, I'm here showing you the patient with the limb girdle muscular dystrophy. Here you can see that the tibialis posterior appears to be relatively preserved, and maybe some of the anterior compartment muscles are also okay, but the posterior compartment is definitely significantly replaced by fat and connective tissue. So in our first case, that is the patient who had this is the patient with the 15-year-old boy who had 2-year history of flaccid weakness, element type of weakness, but preserved reflexes. We can see that there's sparing of the multifidus, the quadratus lumborum, tensor fascia lata, adductor longus, biceps femoris, and sartorius. From the literature, when we look at MRI patterns of muscle involvement in SMA, it's very variable. For Brona et al. In 2020, they presented a series of case series of multiple patients with SMA, which they grouped as SMA2, SMA3 non-ambulant, and SMA3 ambulant. So this patient was ambulant, and from their series of about 20-25 patients for whom they had muscle MRI, they showed that there was a proximal to distal gradient. There was a relative sparing of the adductor longus, adductor compartment, particularly adductor longus in the thigh, as well as the tensor fascia lata, which is what we have seen in our patient. Below is a panel that they again provided that shows the progressive involvement over time in these patients. Our patient is somewhere over here, probably in C. And with advanced disease also, you can see that the adductor longus still appears to be preserved. For the lady who presented with absent reflexes and flaccid element type of weakness, what we saw was there was already a significant involvement with, and so we could only talk about what is less involved. So possibly gracilis, sartorius, rectus femoris, and tibialis posterior were less involved. And this is the pattern that we can expect in a patient with dysferrinopathy. So both gracilis and sartorius being preserved, and rectus femoris also being preserved, with tibialis posterior having variable involvement. So again, coming back to our cases. So we had a pure motor element type of weakness with proximal more than distal weakness. Some with preserved the boy with the preserved reflexes, and the girl and the lady with the absent reflexes. Distinguishing features in these patients are EMG, which in the boy's case showed a neurogenic pattern, and the lady's case showed a myopathic pattern. And we have established that the muscle MRI pattern also shows a differential involvement. So we can possibly consider spinal muscular atrophy for our boy with preserved reflexes, whereas muscular dystrophy, preferably limb girdle muscular dystrophy, for our lady with absent reflexes. But still leaves the question of what genetic test to order. So the most important consideration when we are ordering a genetic test is what resolution we want. So in case we are looking for chromosomal level abnormalities, either a addition of a chromosome or a loss of an arm of chromosome, then karyotyping is the way to go. But changes which are, but the lowest resolution with which it can identify abnormalities is about 3 megabase pairs. When we come to nucleotide level abnormalities, such as duplication or a deletion or a missense mutation or a frameshift mutation, sequencing is the way to go. For anything in between involving genes or exons, we can consider molecular cytogenetics, such as FISH, CGH, things like MLPA, which comes somewhere in between the molecular genetics and the sequencing methods. So to identify which tests to perform, we do need to have some understanding of what is the genetic defect that we are trying to evaluate. So this, I think, Jairam briefly presented. I will just very rapidly go through it. So we have two genes, SMN1 and SMN2. SMN1 is the one that is lost in patients with SMA, and both copies of SMN1 will be lost. And SMN2, there will be increased transcription of SMN2, which is not normal. And these SMN2 transcripts are unstable, and they do not result in much of functional protein. And that results in the disease per se. SMN2 can increase in the number of copies of SMN2 can increase, and this amplification of the number of SMN2 copies will result in the gradation of the disease, that is SMA 0, 1, 2, 3, and 4. So as you can see, the level of defect is at the level of a gene. So we want to know how many copies of a particular gene is there or how many copies of a particular gene is absent. And this can be ideally done by using a multiplex line probe assay or the MLPA. So in MLPA is different from sequencing in that we do not actually use transcriptase. What we use is a ligase. We present primers from both ends of both the 3'N as well as the 5'N, and the space in between is copied from the template strand using ligases, and then this product is amplified. And the result of an MLPA is often like this. Here is the control patient. So it in normal, if there is a normal copy number complement, we will have about the amplification ratio will be about 1. As you can see here, all of the transcripts have an amplification ratio of about 1. In patients who have defective number of copies, that is in patients with SMA, what happens is this ratio falls below 1, often to about 0.5 when we talk about exon 7 containing primers or exon 7 containing segments. So as far as dysferlinopathy is concerned or LGMD is concerned, the defect here is at the level of nucleotide. The dysferlin itself is a large gene with almost 55 exons and is located on chromosome 2p. More than 400 reported mutations are there, and unfortunately, there is no mutation hotspot. So it can be both exonic mutations, it can be intronic mutations, and it's spread almost equally all along the gene. So for this kind of defects where the problem is at the level of nucleotide, gene sequencing is the way to go. Oftentimes, if the gene sequencing is also negative, but you're still strongly considering dysferlinopathy, the dysferlinopathy itself can be proved by doing an immunochemistry for the dysferlin-caveolin complex. So sequencing, again, there are 3 types of sequencing that we can do: targeted panel sequencing, whole exome sequencing, and whole genome sequencing. So targeted panel sequencing, basically what we do is we capture the genes of interest or the exomes of interest, and then we amplify, and then we try to identify whether there is any abnormality in them by sequencing them. In whole exome sequencing, on the other hand, we target all the exomes and then we amplify them. In whole genome sequencing, there's no such capturing step at all. So basically, the difference between the 3 is only about the library preparation. So targeted panel depends upon what are the targets that we are using. Whole exome sequencing obviously misses all the introns, and whole genome sequencing is information overload. So we can pick one of these approaches. Ideally speaking, targeted gene panel is the best way to go. But in our patient, we went with whole exome sequencing, and that resulted in our diagnosis of LGMD with dysferlin mutation. So in summary, so when we have your clinical features, we look for distinguishing features. These can be EMG features, these can be muscle MRI features or some other muscle imaging features. And then we go ahead using all this information and our underlying understanding of the disease, we can order various genetic tests. Thank you.
Okay, thank you, Dr. Rajeshwari. I think Dr. Vaibhav is gone or he's still there? Yeah, yeah.
No, I am still here.
Yes, yes, sir. So you want to say something? Then we'll take up from the audience.
Yeah, have you discussed the role of MRI for the biopsy, if possible?
Actually, biopsy is nowadays not really done for most degenerative disorders. The
Yeah.
only indication for muscle biopsy is when your clinical picture and your MRI and your genetic tests are not really speaking the same things. For instance, if in this patient dysferlin was negative or the dysferlin gene mutation was negative, we might have considered doing a muscle biopsy and done an immunohistochemistry for dysferlin complex. But that being said, muscle MRI to guide muscle biopsy is usually done in cases of inflammatory myopathy, where we can identify areas of muscle involvement and then we can use those areas as to sample the muscle.
Yeah, currently, muscle MRI has become more of a functional studies after the genetic testing. So if you want to, for example, if you get a single hit of a dysferlin or any autosomal recessive, you get a single hit and you don't, I mean, you're clinically very suspicious of that. One way of proving it is to do a muscle MRI and then actually you can look for the second hit in a whole genome sequencing or something. So that is one way of doing it.
In fact, I think they proved the myofibrillar myopathy using muscle MRI on a follow-up patient because these were not known. These defects were not known. That's a very interesting case study.
Yeah. So other that is one thing of muscle biopsy thing. Second thing is sometimes even when we do muscle biopsy, I see some patients need a closure. For example, if you are a whole exome sequencing is negative and the rest of things are negative, at least muscle biopsy will tell you that it is a muscular dystrophy. That much at least you can be sure that it is a dystrophic process. I think patients sometimes need a closure for a diagnosis. That also sometimes if everything comes negative, we still do a muscle biopsy for that case. That is one. Second, I think did you? I mean, I have to ask. I'm not sure because I got a call in between, so I missed. Did you talk about FSHD genetics?
No,
No,
I
yeah.
did not talk. I didn't talk about
So your talk was on LGMD, but one thing which a lot of people miss is because a lot of patients, because most of the FSHDs which come to me, most of them are initially diagnosed as LGMDs, and most of them undergo muscle biopsy, most of them undergo whole exome sequencing. They come, all of things is negative. So if you don't,
Vishnu,
yeah.
you have a lot of work with FSHD. I just have one question. It is not related to this case. Means many huge chunk of FSHD, I believe, is facial sparing also.
Yeah, there is a significant. I mean,
So
I have been
it's
fooled.
significant.
I have been fooled as thinking of FSHD a lot of cases. So in
So
fact,
in those segment, how specific and sensitive is Beaver sign? And how we can suspect
Beaver is pretty
FSHD?
good. I mean, Beaver. I mean, I would say Beaver. If it depends upon the number of units. I mean, if you have a severe FSHD, if less than 2 or 3 units of deformism, Beaver is usually present. So if you have a borderline case of 6 to 7 units or around 8 units in that case, if there is there, and I mean, FSHD is such a big mimicker, so that if you test the family members, they may be evolving. If you are seeing at a child at the age of small, I mean, less than 10 years, they may be having a mild weakness. They may develop a Beaver later on. So at what stage of the life you are seeing an FSHD, then that also depends upon that. And most important thing is that there are patients who are there are hardly any very mild facial weakness FSHDs are there. The other way around, there are Beaver negative, very severe weakness FSHDs are there. So the more and more cases that we see a lot of atypical cases. But that said, for a general neurologist or for a resident purposes, I think these atypical cases should not blind you from seeing the common things first. So common things first. So
means Beaver positive will take you towards the FSHD.
yeah, in 90%, if you have a very severe weakness, severe lumbar rotation,
it is not present in other LGMDs.
yeah, it is seen in GNE. It's a considerable number of GNE myopathies. I think not Nalini has a paper also on GNE myopathies and having Beaver. Beaver sign in GNE. GNE also can be seen, but the presentation of GNE is entirely different. You have a significant quadriceps sparing in GNE will be there.
That's
In FSHD, you will get actually quadriceps will be more affected. If an FSHD have a proximal weakness in the lower limbs and a distal weakness, quadriceps will be affected. Quadriceps will not be spared in an FSHD with a proximal and a distal weakness in the lower limbs. So GNE, you will have a alleged quadriceps sparing will be there. In that case, it is important. And my major point here and to say FSHD here is not because I want to say about FSHD genetics. The point is that not to do biopsy or not to do whole exome sequencing for the first instance on FSHD. You might pick up a 1 or 2% of FSHD2 in a whole exome sequencing. Rest everything is going to be negative. So you may not. So I've seen people writing FSHD and writing whole exome sequencing and send it the patient for a whole exome sequencing. You will not pick up a whole exome sequencing on an FSHD. If you're there in those things, you need a specialized test of southern blotting or optical genome map. Okay, then anyone else? Any other questions from anyone? Let's see the panel, anyone, or the question answers. So most of the other question answers you have answered those things. And the other interesting part of genetics.
Yeah, are you aware of any grading of small muscles of fingers? Somebody
No, I mean, I don't think so, because you can
mostly
grading with the muscle. If you actually somebody wants to follow patients with small muscle weakness and you want to do a trial or something to do a small muscle hands, you can actually use a handheld dynamometer, but that is more muscles also. It's not just the small muscles. Forearm muscles.
It is mostly subjective only, I think.
Subjective only. And if you want to do a muscle MRI, as madam told, muscle MRI is one to objectively measure the size of the muscle. You can do a muscle also maybe used to measure. So
maybe the person who asked can develop a new grading.
Okay, that is one other thing I wanted, because we are selling about dysferlin, because it is an autosomal recessive. There's an Australian group recently published an autosomal dominant dysferlin, and so they put up a full family or this one. So that was a very, I mean, because we see a lot of single hit autosomal, like you get a one single hit and you label it as a variant of unknown significance. Unless you get a compound heterozygous or a homozygous thing, you don't genetically diagnose it. So the moment you realize that such a thing exists as like an autosomal dominant dysferlin can also exist, now you get a single hit. Always look back and see the parents. So examine the parents are also equally important. When they say family history negative, an examination of the parents is also equally important. Something else is important.
Possibly examination of all the available relatives.
Yeah, all the available relatives. That's a good learning point. I think we have overshoot by around 20 minutes, but that's okay. So it's a very interesting session. And I would thank everyone. Both the residents did an excellent job, and both Dr. Vaibhav and Dr. Rajeshwari both have been doing very well. And it's my alma mater, JIPMER, is presenting. It's very nice to be moderating that session also in that. So, and the next session is from NIMHANS after 2 months in October. I think NIMHANS, Dr. Nalini and his team, Deepak Menon is still there here, and the Sina and everyone else will be presenting from the NIMHANS team on October. And also, I just want to share one slide before going, so 1 minute. Let me see if I can share that one slide. It is just for the subsection meeting. So can you see the slide? I hope you can see the slide. Can you see it? Can anyone confirm that you can see it?
Yeah, we can see it.
Yeah, sure. So you have a neuromuscular subsection meeting at IONCon Madurai on 15 September at 4:30 to 5:30 at Hall D. I think it's Hall D. So we are doing a neuromuscular blitz. That means we'll have a very short case. We will not present you a big case or something. It's more of a learning experience as a spotter-like thing. We have in one slide or maximum one slide the whole thing, and or a video or a photograph or something. We are collecting cases from all our subsection members and trying put it into a 1 hour session in the neuromuscular subsection. So very interesting should be very interesting and teaching experience for.
And we can share few cases, yes.
Yeah, at the IONCon subsection. So that's something which I wanted to tell. I think I should just, okay. Stop share. And thank you everyone, and have a nice evening. Thank you.
Thank you. Thank you.
Bye-bye.
Thank you.
Bye-bye.
Good night.
Good night.